having a panel discussion on the topic, the role of technological innovations in community-based strategies for finding missing tuberculosis cases in Nigeria. We know that Nigeria ranks sixth globally in terms of TB burden and first in Africa. And we are aware also from the latest WHO global report that our treatment coverage is barely 30%. However, we have 88% treatment success rate. But again, it's interesting to know that 71% of the TB patients in Nigeria suffer catastrophic costs in a country with about 69% of TB budget unfunded. And the NTBC with and its partners have developed a lot of strategies to find these missing TB cases. And among these strategies are the deployment of technological innovations for finding missing TB cases. So today, we will be discussing some of these technological innovations that have been deployed in the TB program in Nigeria currently. Two systems that we'll be talking about this afternoon: the mobile application for tuberculosis screening, MATS, which was upgraded for TB screening and notification by the Institute of Human Virology in collaboration with the National Tuberculosis and Leprosy Control Program and Pharmacists Foundation with funding support from the Global Fund. That app was deployed in 2020, June precisely, and is being used in 21 states of the country currently. And then we'll be looking at the second system, EPCON control, epidemic control platform, EPCON. This system was also developed by, in collaboration with EPCON, Belgium, the National Tuberculosis and Leprosy Control Program, and the Institute of Human Virology. That system was deployed for use January this year, and is used currently in 4 of the southwestern states of Nigeria. So this afternoon, I have a wonderful group of panelists that will be looking at these systems and also discussing the role that technology has to play in finding missing TB cases in Nigeria. On my immediate right, I have Mrs. Olawumi Oyadonga. She's an MI officer at the National Tuberculosis and Leprosy Control Program. And welcome. And just beside her is Mr. David Meshach. He's a program officer and a programmer at the Institute of Human Virology, Nigeria. Next to him is Dr. Tafikat Ali, a program manager and the coordinator of the Global Fund Public-Private Mix project at the Institute of Human Virology, Nigeria. You're welcome, man. And next to Dr. Tafikat is Mr. Vincent Murint. He is the director at the EPCONs in Belgium. You're welcome, Mr. Vincent. And sitting very close to Vincent is Dr. Ademola Serrano. He is an innovation manager at the Pharmacists Foundation in Nigeria. Dr. Serrano, you're welcome. And then at my extreme right over there is Dr. Abiola Alege. She is of the Society for Family Health, Community Mobilization Officer, working with the TB Loan 3, the Institute of Human Virology, Nigeria, in the Southwest. You're welcome. So we dive in and start eating at this on this plate that is set before us, the role of technology. But first of all, we'd like to know, maybe David or Vincent will give us a brief overview. Maybe we'll start with David, a brief overview of the MATS app. What's the MATS app?
Okay, thank you for having me. The MATS app stands for Mobile Application for TB Screening, and it's an Android-based device that is used to identify presumptive clients. Usually, it is deployed at facilities or the community settings, whereby it is used to screen based on some algorithms to identify presumptive cases.
All right, great, thank you. Mr. Vincent, you want to give us a brief overview quickly of the EPCON system?
Yes, thank you, David.
Yeah,
sure. So EPCON actually built a platform using machine learning technologies that makes use of high-resolution contextual data and variables like population density, air pollution, all these kind of contextual data. When combined with programmatic results coming from the field, It dynamically generates and propagates TB burden across the 4 states. So you don't need TB results from one location, you actually project it and then provide you some estimates as to the expected yield of the program.
This is great. I see some wonderful technology work there. Maybe later you give us some more updates on that system. But I want to know, I mean, technology in TB program. Dr. Trafika, what inspired the development of the MAXA, for instance? I know Institute of Human Biology in collaboration with NTP and the pharmacists brought up that system. What inspired the development of that app?
Thank you. We know that the TB grants is in the private sector where the MAS app is deployed, so it's used in the private setting. And we know that the private sector, looking at our data, our statistics in Nigeria, a lot of people visit the private sector. At least 60% of anyone who is ill, would visit the private sector. So it provides a huge potential to find the missing TB cases. So with that at the back of our mind, we also looked at the unique feature of the private sector where they have few hands in terms of persons available to offer services. So it means time is of the essence in the private sector. So at the inception, we realized that we need to develop a tool that will make it easy to find the missing TB cases in the private sector. So that is the major focus in developing the tool, where you have a system that is fast, that is reliable, and very user-friendly in screening for TB. So it's very simple, and it makes it very easy for the private care provider, reminds them, prompts them to ask for TB, screen for TB, and record such cases. So it helps us bridge that gap in finding the cases, reporting them, and managing them subsequently.
That's great. So we are seeing technology bridging the gap, in all of the cascade of care. This is wonderful. For the EPCON, I know the EPCON is used currently in the southwestern states, and Vincent just gave us a brief overview of the EPCON. I mean, what inspired? Why EPCON, Alege, Dr. Alege? Why EPCON? I mean, there should have been some other systems. Why EPCON? Why did we? What inspired that?
Thank you very much, Mr. Moderator. So, with regards, you've stated it now, just before, while you were introducing us. Nigeria is a very high-burden country, and we contribute about 4% of the missing TB cases globally. And it was imperative to find a way to allocate our resources into areas where we get the most yield. And that was why we had to come up with the idea of artificial intelligence. And we have other countries that have used it successfully. For example, in Pakistan and India, Bangladesh, and they've been very successful at it. And that was why we thought that it would also be useful to us if we are able to map our hotspots and then target our interventions, especially in the community. We know the cases are in the community, and then we need to find them most efficiently with our limited resources to find.
Wow, that's wonderful. Resources. We are resource constrained, so we need to put our money where we can get the maximum output. I like that. Please, just to mention to participants, please, if you have any question, you can write them down. Somebody is within us, Mrs. Sandy is there, so you can just write down your question, you pass to her. After the discussion, we can take your questions. Thank you. Yeah, so we see that in all of this system that we talked about, we see the collaboration with the NTP, in all of this development, in all of the deployment of the system. People want to understand from the National TB Program, the role that the NTP play in all of this. What's role they play?
Okay. The role of the National TB Program in all of the platforms, both the MAP app and the EPCON, was coordination mainly. Coordination at the national level and at the state level. During trainings, the state MID officers are involved, and also to set up the systems. Because we're going to be using screening for populations, we had to make sure that the algorithms were standardized, and the algorithm being used on this platform should be the same thing with what is in the national policies. And then we also had historic data that was used by EPCON to set up the initial system to see the original mapping of systems. So the main roles were for coordination and then to set up the systems.
That's good. I mean, we see that when partners, when we begin to work with the TV program, we see that we can achieve a whole lot. I mean, we've talked about the Maths app, wonderful overview by Meshach there. But I'm sure there are some unique features of the Maths app that makes it different from other screening apps, because I mean, there may be some other screening app out there, I don't know yet. But I'm sure Dr. Serrano wants to tell us what makes the Maths app unique. What makes the Maths app a unique app?
Thank you, Charles. Well, first of all, as David mentioned and as Dr. Ali mentioned, it's the algorithm. Right? The algorithm is a clinical-based algorithm. Right? So this enables it to be used in what I'll call low-tech settings, low-resource settings, as was mentioned. Furthermore, the interface. Dr. Ali mentioned the interface is simple. It is actually deceptively simple, let me put it that way. Right? And that enables it to be used rapidly in that sense, in the sense of where we're at the community pharmacy, we're at the health outreach, we're at the health facility, the OPD of the health facility. You want to have fast screening in that place. You need a very, very simple interface. And of course, finally, again, is the ease of adoption. Right? When you're putting this, you're using, if you use a difficult app, for example, an app that needs a lot of tech in Lagos, that's fine. But by the time you go to Adamawa, you go to Maiduguri, it's totally different there. You need an app that can be used in a low-tech setting. So again, the app is used in very, very low bandwidth. You need a smartphone, but very low bandwidth, low RAM in that smartphone. You also have the offline mode, where you don't need to be connected to the internet to continue screening.
That's
right. Very, very wonderful. And again, we continuously iterate. Right? We are still developing the app, we are still iterating on it, we are still talking to others also about how to make it even better.
Wow, that's great. So it's like a living system.
Yes.
Great.
So if I may add on that, so I think for me one of the things I like about Maths app was the fact that it's an app for Nigerians that was built by Nigerians.
Oh, great.
So it's always the idea that whenever you needed to do certain things, maybe there's a change, is always close to you, and you can discuss with the developers close in the in-country and make any adjustments as the need may be.
So the developers, they understand the context, they understand the situation where the app is used. That's great. Local content. That's great. Thank you. I mean, Vincent wants to tell us some things about the uniqueness of the EPCON.
Yes, thank you. I'd like to. So I think one of the big challenges, and actually this is not unique to Nigeria as well. I mean, with COVID, we've seen the whole of Europe in panic basically because they didn't know where to target their interventions. So one of the unique features that we can do with the EPCON platform, because we use these extremely high resolution data, we are capable of translating that into output that really relates to the community healthcare worker in the field. So it's really about telling them, like, listen, at this location, that's the expected TB burden, that's the expected yield, and that is your target for the number of screening people to find one TB case. So that is really the way in which we approach it. That makes it quite
unique,
strong.
That's great. Thank you. Thank you. I mean, who are the users of this app? Maybe you want to say, who are the users?
Well, typically we see different kind of users. So you might have a scientific community that's interested in really learning at how the different variables correlate with each other, and to what degree they have an impact in the progression of the disease. But then you have obviously the planning. So, and that can basically be a top-down approach. So you could either have, from an NTP perspective, looking at national, state level differences to really identify, okay, what resources are we going to deploy in what region. But then when you bring it down to daily planning activities, you're really looking at planning coordinators, and they're going to be able to tell you, like, okay, tomorrow these are the areas that we're going to be screening. And I think the ideal scenario is even when you integrate it with tools like Maths, that you can say, like, to the users of Maths, like, listen, where you are now, that's what you should be looking at. So
it's like Dr. Alec wanted to say something. Yeah.
Yes, thank you. I would like to add that all cadres of staff can actually use the EPCON platform. And especially the frontliners in the community volunteers, CBOs, the state program manager can use it to plan interventions within his jurisdiction, the LGTBLS, all cadres of staff. And we are also looking to integrate the PPMVs.
Just hold it there. We are going to come to that. Integration is very key in technology. We'll come there.
Alright,
David
so-
wants to tell us.
Yes, I wanted to talk about the
Users.
users of Max App. So for Max App is essentially, we have like two categories of users.
Okay.
We have those we call the administrators. In that category, we have, that's where the national program, the state program, the ISBN, the program admin. We have also the SR, sub-recipients who coordinate the, let me say, the day-to-day users of the system. And the second category are the, like the PMPs, like she mentioned, we like to call it, I would say, referral entities from Mass. Because we believe they are the ones who carry out the screening, so they are the main users. Some of them could be PPMVs or community pharmacists, or could be screening officers situated at the facilities. So they are the other category of users. And so they are the ones who carry out the screening, while the administrators from the back end ensure that it's done well.
Thank you so much. So, but like I said, if you have any question, please just note it down. Sandy standing behind it, you can just raise it and she'll pick it up from you. Thank you so much. But let me stay with you, David. Can you give us an update? What has happened? What's the result? I mean, we talked wonderfully about this technology. What have we? We talked about this for screening, for notification. Can we get some numbers?
All right, so since from June 2020 that we deployed the Max app, so far we have about over 500,000 screening done with the Max app.
Wow.
And from that number...
in all 21 states?
Yeah, 21 states.
Wow.
And don't forget, initially we started with 20 states.
Okay.
The other states joined close to the end of the year. So
Okay.
we still have like over 500,000 screening done. And from that we had about 42,000 presumptive cases from these 500 plus screening, and we've diagnosed over 1,700 plus cases from the Max app.
Wow, that's great. That's great. That's great. That's wonderful. Dr. Legge, you want to tell us what result have we seen so far with the F1?
Okay, since the inception of the TPMP project, we've been able to diagnose more than 22,000 cases.
Wow.
And about 30% of this come from the community. And if you look at when we deployed, we rolled out the EPCON app. We started from 1 or 2 states, maybe late fourth quarter 2020, and we fully deployed to the field January 2021, like you stated. If you look at our statistics, both from the project and within the states across the states that we cover, you would see that there was a spike in the cases diagnosed with right from quarter 1 2021, which showed that it was due to the deployment of the app.
Okay.
We were using the app to identify hotspots, and so we're targeting our interventions, and we're getting more from our activities compared to when we were just working blindly without any guidance or guiding our activities.
Thanks. So maybe we can go to that question. We were about to address integration. So what are the future plans? What are the plans?
Yeah.
Okay. Mr. Vincent wants to say something about that. Future plans for the EPCON.
Well, in terms of future plans, of course we always continue enriching the platform with additional contextual and predictive variables. And so one of the key elements in that is actually feeding dynamic live data into the platform. Because as it's dynamic, it continuously learns, and it will actually continue improving its algorithm, or it's targeted planning actually. And by feeding it in with, for example, live data from screening from MATS, Gene Expert, potentially chest X-ray results and so forth, you really get a dynamic interactive platform that allows you within an organization and within a state to really coordinate your planning.
Yeah, that's good. So we'll take one response question, and then we have a video on MathSAP and EPCON for us to see. But before we play that video for Maths first, let's hear from David. Every technology has its own challenges. Maybe let's hear from Serrano, Dr. Serrano. Every technology has its own challenges. In the development of, you were in the team that, upgraded the system. What were some of the challenges that, encountered while developing the system?
I'll start with, First of all, that clinical algorithm. Right, you heard the NTB, LCP rep there talk about how their role was to coordinate and standardize. Right, they really did that when it came to the algorithm. I think they took us through it.
They have to trust that they are EFCC of NTB.
I'm telling you, and that was one. That was we had our own experts internally. We sent it all over the world to look at it, and we came back to Nigeria. IHVN helped us, NTB, LTP helped us, and that was the first thing. The second thing, of course, was the development of the interface. We had to do a lot of user panels. Doctors and health workers are known to be very resistant to technology adoption. So we had to do a lot of user panels, we had to do a lot of demonstrations to the key stakeholders, right, before we could get that interface right. And don't forget, it had to be a rapid use interface. 2 minutes, 3 minutes, you're done with the screening. That was extremely important. And of course, funding. Right? That's any project, any development project, especially a tech project where at the initial stages it's capital intensive.
Yeah.
There's always a funding problem. People don't see what you're going to get out of it, or it's hard to see what you're going to get out of it at later stages. So we had that problem funding. Yes, Farm Access did initial, then by the time IHBN and NTB, LTB came in, it was wonderful. And they took it for further iterations at that stage.
Great, thank you. So maybe we'll quickly watch the video on the Maths app, and then we will hear from Vincent some of the challenges as a developer, and then from David of maybe Africa to tell us on the implementer side. Yes.
But I'll just take us through it. This is the dashboard. You click on the screening icon. You have to ask your patient for consent, and this is the consent page. This is actually very important, as we know. As soon as you click the consent box, the first screening questions come in. You have to check the respondent, who the respondent is, the HIV status of the respondent, the cough, presence of cough, duration. Finally, the whole screening algorithm takes you to whether the person is presumptive or not. If the person is presumptive, as we can see here, or this is not presumptive. Okay, yeah. So let me go back. Sorry, I'm trying to look. Okay, you end the survey.
If it's not presumptive.
Okay, this is if it's not presumptive.
Yes.
Yes, and that's a very quick one. If the person is presumptive, then the person needs further evaluation. And this is where we collect the data of the person. We have personal data to collect. We also have contact details of the person to collect. And then we refer the person to the closest referral facility to that person. This is a very important part of the notification process. As soon as the person is presumptive, I have to say this again, notifications go out. Notifications to the person, the individual who was just screened, that yes, there is a presumption of tuberculosis. Notifications to the referral facility, that yes, this person has been deemed presumptive and please expect this person to come in, as well as notifications to the program managers that yes, somebody has been deemed presumptive, so that they can be follow-up, so that they can be linkage coordination, let me put it like that, across all these three spheres.
Great, thank you so much. So let's see for the EPCON. Let's get the video for the EPCON and see, take a quick walk through the EPCON. Please, if you have any questions, you can put them down, raise it up, collect them, and then we'll talk about them very soon.
Just wait 1 second.
Okay. So while we're waiting for that video, maybe David want to quickly, okay, it's up.
Okay.
All right.
Yeah, so this is an overview of the EPCON platform. So what you see actually is the different locations where, for example, the team has been screening during the month of June. That data, we can combine it obviously with healthcare facilities, and the model actually uses healthcare facilities as well to calculate the distance to the near facility for the population as well, because we see that that is a contributor to indeed progression of disease. What you see now is that these individual points, these point locations, are aggregated at a higher resolution, which are at community level. So it is a computer-generated algorithm that defines population clusters of 10,000. And that then allows us to propagate across all the states what is the expected TB burden and where have your screening activities taken place. And that is continuously updated as these screening activities are actually happening. What we can then do, because these are obviously high resolution population clusters, is we can aggregate that to a higher level as well. So we can actually look at the results from a ward perspective, an LGA perspective, or a state perspective. So that allows you to really look, okay, what has happened and what does it represent in an aggregated format, and what are potentially the areas that we need to focus on in terms of providing better care or reporting facilities or screening activities and so forth. So what you see now is actually the aggregation of the TB estimates at ward level in combination with the screening results as well. And so what you can see on the right-hand panel is you actually see the expected yield. So this was a very brief overview. I want to keep it short.
Thank you so very much for this. Maybe you just continue from there. What are some of the challenges we encounter in developing the system?
Well, obviously data is a big challenge, like for everybody. The digital aspect of data, so the digitalization process of the data, has definitely been a challenge, and we did succeed in getting that one covered. So what we do is we actually automatically feed data from Google Sheets into the platform, use that then in the algorithm to propagate what is actually happening and to measure the yield of the programs against the estimated burden. And then in order to get high resolution model predictions, we actually need to reduce all the data into a high resolution scale as well. So that is also an additional challenge. But we've done that before, and so we do know how to deal with that. But in order to provide that precise output, that's really needed to do.
Great. It's like Dr. Legge want to add something quickly.
Yes, I would also want to, from the implementer point of view, we had some challenges. And the first, just like Vincent mentioned, one of the major challenges we had was we had paucity of electronic data. Most of our data is paper-based, so we had a bit of a challenge getting them together, but the NTBC was actually very instrumental in helping us to collate these, and then we were able to deploy into the model. Another challenge that we had was that community intervention activities were not being reported as community data. Okay. The cases were mapped to facilities, and when you need to analyze, it gives a distorted view of the community activities. Okay. For example, if let me use an example of Ibadan, where we have the UCH or Jericho General Hospital, Jericho Chest Clinic. When you look at the data from the facility, it will give you an impression that there is very high burden TB around the UCH or Jericho Chest Clinic. But when you look at it, especially in Nigeria, where stigma is still a very huge problem, patients often travel a long distance to be able to access care. So we had this challenge, but we were able to surmount this by starting small. We started with community data being generated from the TB Log 3 project, and then we built up from there. Okay. Also, limited digital literacy of most of the frontliners. If you can look at the video that was shown earlier with regards to the dashboard and show portal, it was a bit challenging getting our CVs to sit down and say, you have to look at the laptop and look at this and it. But we're also able to overcome this by deploying the WhatsApp alert, that everyone has access to WhatsApp, and it was quite easy for people to resonate with WhatsApp. So you can actually query the burden and actually put in your data. Then, like has been said for the WhatsApp, internet, data, devices, we're also able to overcome it by the time we deployed the WhatsApp alert. Then another one that I feel that I'm sure that will be the simplest, but it's still a bit of a challenge to us. We still require the NTBC, they be very supportive, but we still require them to give formal assent to the states so that they will be able to deploy this model across all the states. And it can do so much more than it's doing presently, because the state would be able to coordinate the activities of all partners within the state and actually have a holistic view of all interventions.
Thank you so very much. Thank you so much. I mean, we cannot run away from the impact of COVID on the TB case finding, and I'm sure this technology also, there was some COVID impact on this technology. Maybe David or Tafika, who wants to, what was the impact?
Yes, with the COVID, the WhatsApp deployment, the deployment was at the peak of the COVID pandemic. We launched in 2020. That was just as we were getting out of lockdown. So it meant we could not even move around to do the necessary trainings and capacity building that was required. So the healthcare workers, the end users who would need to be trained on the use of the WhatsApp, we could not do that physically. So we had to resort to doing virtual trainings. So the department, the unit, developed video trainings and did that over several weeks. And in fact, there was ongoing sort of capacity building on routine basis where people could log on and learn more. So that was when we were able to address that. But the other thing, just as has been said, is also, of course, we know the internet connectivity. Even though it's a low bandwidth technology, but you realize that there are still areas you'll get to and there's absolutely no data connection. So again, working with the developers, and as we said, that's the beauty of this technology. They're right here in the country. We quickly resolve challenges because we're speaking together, we can see them. So we also developed the offline model where even if at the point of use, there is no data, once all that data has been logged on, once you get to a place where there is internet, then it's uploaded. So that was another major one that we were able to solve.
This is great. Thank you so very much. So we'll be winding down right now. We have a question here from one of the participants. But before that, 2 more discussions and we'll be done. David wants to tell us the future of the matter.
Okay, yes, of course, so far we can only see where we are, but we can always dream of the future. For the Maths app, we're already working on integration with other systems, including right now we're integrating with Nigeria Interbank Settlement System, which is used for payment. The program requires the incentive payment, so we'll be looking for ways to improve the incentive payment. So that's why the need for us to integrate with NIBDS. Also, we're also looking at integration with GX Alert, which are other netting system, Nigeria Electronic TB Information Management System. There are different systems in the nettings, and we look forward to integrating with them.
Oh, great. Thank you so very much. So maybe allow me maybe help us again. The TB program, technology, finding missing cases in the community. What are your recommendations as a national program? What do you think? Which way forward?
Okay, so as a national program, of course, our mandate is to find all the missing cases. We are doing this, of course, in line with the NTB strategy, one of which is use of innovative research and technology. So we cannot run away from the future, which is technology. So technology, of course, we're hoping to use it for early diagnosis, which is the screening part, taking technology to the communities for screening, and also the testing and getting results promptly instead of waiting for paper-based results to get back to the health facility. If we can have instant result to the person who sends the test, and even if we can get one to the patient. So then, like Vincent said, we can also use technology for hotspot mapping. So by the time we're programming at the national level, we're using real-time data to be able to direct partners, to be able to direct even our state and TBLSs, okay, these are the communities where we should target, because we have limited funding in the country. So once you have limited funding, you have to prioritize. And using technology is one of the fastest ways to prioritize and effectively prioritize and use your resources judiciously.
Prioritize, resources. Oh. I think someday we'll have all of these resources and we'll stop talking about this prioritization very soon. I get so. So there's a question here, maybe Serrano or David. I'm sure this refers to the Maths app. What is the time lag between the notification of the presumptive and actual investigation for diagnosis? You said the Maths app is used for screening. So what's the time lag between the time cases presumed to have TB and then diagnosis is done?
That's actually a great question.
Yeah.
Really, and that depends on patient presentation, right? Which is a voluntary activity. I have to say that, right? So once someone has been deemed presumptive, right? I said 3 notifications go out: 1 to the patient himself or herself, 1 to the referral facility, and 1 to the program managers. The referral facility is expecting a patient with certain details to come in for a confirmatory diagnosis. It's left to the patient to actually make that effort to go to the referral facility and get that diagnosis. Now, the reason why we send to the referral facility is for follow-up. The referral facility is also expected to follow up. Oh, you got a notification 2 weeks ago that this patient has been deemed presumptive and that patient hasn't showed up. The referral facility to follow up, calling the patient and trying to encourage the patient to come in, right? So the time lag, like I said, it's a voluntary activity. It's very, very hard to say that, oh, within 1 day this patient will present, within 2 weeks this patient will present, because it's a voluntary activity.
I'd like to add to that. So one step we've taken, the linkage coordination, you know, so the linkage coordinators there, who will ensure that as soon as that presumptive case is generated, the patient is prompted, he's linked to the facility for diagnosis and the result. And I think our data shows that our losses are very minimal because we're following up our patients and we're keeping them in care.
That's good. Is the Maths app on Google Play Store?
Yes, the Maths app is on Google Play Store.
It's on Google Play Store.
But you need access. You don't. It's not for everybody.
So it's important that.
Why do I need access? I could just pick it up and start screening and send.
No, you need access because of the linkages and the coordination.
With the
you
NTP.
need access.
Great. So I mean, you don't just put data and just start putting data into the system. It has to go through the national reporting system. Thank you so very much for that. This is to, I guess, to the NTP. How can we facilitate access to data for upload on the system at the state level?
Okay, so like I said earlier, the role of NTBC is coordination. So what we want is for if you require data, you can write to the national coordinator, and as they've already said, the M&E units were ready to provide data. But we don't want people working in silos because every information still has to follow into the routine programming. At the NTP, we are not managing projects, we are managing a program that covers the lives of every Nigerian. So we're not just looking at the public sector or the private sector or all the silos everyone works in. But we don't have an issue with facilitating provision of data. I'm sure Matt's app and EFCON will be able to attest to that. If you need data, just write to the national program, and then if we have to tell the states to provide the data, we'll also inform them.
Thank you so very much. So, on a final note, the delegate want to say something?
Yes.
In 5 seconds each, and then we'll be done.
Okay, I just want to let us know that we can actually do so much more with the EFCON platform. And like the question you asked the other time about the future, we can actually do a whole lot looking at the transmission pattern, genetic sequencing, and even link to other disease programs. And the beauty of it is that the EFCON model is predictive. It doesn't wait for the patient to come, and I think that's the way to go. Actively looking out for these cases, unlike what we used to do in the past, that we wait till the patients come to us, then we use that data to go in search of the patient. But now we can actually predict before the patients come out, and we are to some extent sure of what we are actually looking for.
Great, thank you so much. So, on a final note,
I think
maybe as you give your final note, maybe you want to talk about this. How does your app address screening of extrapulmonary TB as well as TB in children, considering the fact that it presents differently?
well, we actually have a different algorithm for children on the app. So when you present, you have to state your age range. You can either screen an adult dependent, or screen children of 2 different age ranges, which follow 2 different algorithms that are particular for that age range. So again, like I said, the algorithm was well vetted. We are taken to the ringer to make sure that it was clinically vetted.
And NTBC compliant.
Yes. Very, very important. I want to pick up on what she said, right? Because we're also in talks with EPCON to integrate, right? They have a very good analysis platform, and I think it's going to be really extraordinary when we have the data coming from us. Maths is a rapid screening tool. As we've been sitting down here, I'm sure over 40 patients have been screened already. We do an average of 1 per minute, right, based on the data that we're getting. So it's a rapid screening tool, right? So when we have all that data coming in, right, from across the country, integrating it into a data analysis platform, working with AI, it's actually going to be marvelous, and I can't wait for that to happen.
Thank you so very much. Vincent, final word?
Yeah, I don't have much to add actually to the two colleagues here. I think indeed that's the way to go, and we are actually extremely grateful to participate in the program as well. We learn from a lot of the other regions that we actively engage in as well, other countries, and yeah, and I think ultimately it's really bringing it down to potentially that one individual patient standing in front of you, and to really quantify, okay, what is the risk for this individual, given all the context, medical history, potential occupational history, and so forth, within these surroundings. So that's really the way to go.
Thank you, Vincent. Dr. Tafika?
I'd like to say that it's clear that investment in data technology would always yield value for money. So it's the way to go for any program at all. But for TB in particular, we must invest heavily, and we must scale up, and we must use. But beyond scaling up and using, we should also integrate. So I'm happy that the two technologies we've spoken about here, we're already identifying platforms for synergy, for integration. If you're telling us, oh, EPCON is saying, look, there's a high hotspot over there, the WhatsApp goes there, screen rapidly, identify the patient, send them for screening, send them for test, and you're able to put them on treatment. So
Great.
let's think of synergy, harmonizing all our technologies, and that will increase efficiency and give us greater yield.
Thank you so much. David, final word.
Yeah, I want to say technology is finally here to stay, even in the TV space. So just encourage everyone to do your best, wherever you are, whatever application is before you. Let's give it a chance. Let's see how it works.
So I'll just have to say that, yes, like every other person has said, technology is here to stay, and as a national program, we fully embrace the use of technology in finding missing TB cases.
Thank you so very much. Let's put hands together for our panelists. I want to thank my panelists for educating us today on the role technology is playing in finding the missing TB cases in our communities. I mean, our discussions today have really demonstrated the fact that technology has a key role to play if we must find those missing TB cases in Nigeria. Technology may not be the answer, but obviously it is one of the answers. Thank you, and have a wonderful conference.
Thank you, Excellent moderator.